Metabolic alkalosis occurs when the blood becomes too alkaline. It results from bicarbonate retention or hydrogen ion loss, disrupting cellular functions and electrolyte balance. This condition can lead to life-threatening complications like seizures, respiratory depression, or cardiac arrhythmias due to impaired electrolyte function, particularly low potassium levels. Blood pH gets more than 7.45 due to excess bicarbonate or loss of hydrogen ions. The alkalotic state interferes with oxygen delivery and metabolic processes, making it critical to diagnose and treat early. Symptoms are based on severity. Mild alkalosis, when pH is between 7.45 and 7.5 D, patients are generally asymptomatic or they have mild fatigue and weakness. In moderate alkalosis, pH from 7.51 to 7.6 Du, neuromuscular symptoms like tetany start to present. Hypoventilation and mild confusion is also common in these patients. In severe alkalosis, when pH is more than 7.6, a variety of serious conditions can present. Neurologically, seizures and coma, cardiac conditions like severe arrhythmias due to hypokalemia, or respiratory conditions like hypoxemia from hypoventilation. Symptoms arise from impaired calcium and potassium homeostasis, highlighting the interplay between alkalosis and electrolyte imbalances. Key presenting symptoms can be classified by systems. Neurologically, we often see irritability, seizures, and coma. Weakness, cramps, and tetany can present in musculoskeletal system as alkalosis-induced hypocalcemia increases neuromuscular excitability, leading to tetany and muscle cramps. Palpitations and arrhythmias in cardiovascular system are most important problems. In respiratory system, we come across with hypoventilation and naturally hypoxemia. Primary causes are loss of hydrogen ions, gain of bicarbonate, or contraction alkalosis. Loss of hydrogen ions can be caused by GI losses, for example, vomiting or NG suction, or renal losses like use of loop thiazide diuretics or hyperaldosteronism. Gain of bicarbonate can be caused by antacid or citrate overuse. Contraction alkalosis is caused by volume depletion that concentrates bicarbonate in plasma. Doctors should seek for clues in patient history presenting as vomiting, diuretic use, endocrine conditions, for example, hyperaldosteronism, and genetic syndromes. Accurate history helps narrow down potential causes and guides diagnostic testing. Hyperaldosteronism-induced alkalosis is one of endocrinological reasons for metabolic alkalosis that can be overseen, and lack of comprehension of pathophysiological mechanism can lead to unsuccessful treatment when ignored. As hyperaldosteronism links hormonal imbalances to electrolyte disturbances, requiring targeted therapy like aldosterone antagonists. If we summarize the mechanism, it can look like that. Aldosterone increases sodium reabsorption and excretes potassium hydrogen ions, causing alkalosis and hypokalemia. Unfortunately, in this case, exacerbates alkalosis by reducing bicarbonate excretion. There are two types of hyperaldosteronism: primary or Conn's syndrome, caused by adrenal adenoma, and secondary, generally caused by renovascular hypertension. To diagnose, we need arterial blood gases to be done. If pH is more than 7.45, then patient has alkalosis. Bicarbonate and partial carbon dioxide levels are very important in understanding if alkalosis is metabolic or respiratory. In metabolic alkalosis, bicarbonate levels are more than 28 ml/h. Serum electrolytes levels need to be identified. Hypokalemia, hypochloremia, and possibly low magnesium can lead to severe symptomatic. If patient anamnesis doesn't lead us to reasons of metabolic acidosis like vomiting, NG suction, diuretic use, and etc., then urine chloride level can lead us to the reason. It is crucial for differentiating between responsive and resistant types of metabolic alkalosis. When urine chloride level is less than 15 mmHg, it suggests chloride depletion, which happens through vomiting or diuretics. It is generally referred as chloride-responsive metabolic alkalosis. Urine chloride 20 mmHg or more indicates chloride-resistant causes as hyperaldosteronism. Key differentials are respiratory alkalosis, presenting with low PaCO2 instead of high bicarbonate, mixed disorders which can be identified through Winter's formula, overlapping conditions like metabolic and respiratory alkalosis at the same time, and hypocalcemia without alkalosis, stepwise tests that should be done, Winter's formula for expected PaCO2 to understand if the disorders is truly metabolic alkalosis and nothing else. Urine chloride only after being sure of pure metabolic alkalosis to identify the reason. Aldosterone renin levels for hyperaldosteronism. Differentiating these disorders avoids misdiagnosis and ensures appropriate treatment. Types of metabolic alkalosis are classified as chloride-responsive or chloride-resistant. Chloride-responsive metabolic alkalosis is caused by vomiting, diuretics, and etc. Chloride-resistant is caused by hyperaldosteronism, Bartter-Gittleman syndromes. Urine chloride level is more than 20 mmEq/L. Chloride responsiveness determines whether saline therapy will correct alkalosis. General principles in treatment are first treat underlying cause. For example, stop vomiting, adjust diuretics. Then correct electrolytes, potassium and magnesium replacement. General management focuses on resolving contributing factors to restore acid-base balance. For treatment of chloride-responsive alkalosis, we should replete volume with isotonic saline, as saline addresses both volume depletion and chloride loss, facilitating bicarbonate excretion. Give IV or oral potassium chloride for hypokalemia, and discontinue or adjust dosage of diuretics. For management of chloride-resistant alkalosis, we should start aldosterone antagonists as spironolactone and eplerenone and treat underlying conditions like adrenal adenomas. In resistant cases, targeting the hormonal or genetic causes is crucial for long-term correction. Hyperaldosteronism treatment can be medical or surgical depending on reasons for hyperaldosteronism. As it isn't the main lesson about hyperaldosteronism, I'm going to just give a small info about its treatment. Medical treatment consists of either spironolactone, 25 to 400 milligrams per day, or eplerenone, 25 to 50 milligrams a day, fewer side effects. Surgical treatment is adrenalectomy for aldosterone-producing adenomas. Both medical and surgical treatments aim to normalize aldosterone levels and correct electrolyte imbalances. To monitor ABG is needed to be done every 2 to 4 hours, especially for severe cases. Also, electrolytes need to be checked regularly during correction. Continuous monitoring ensures treatment efficacy and prevents complications like rebound acidosis. Key takeaways are to first identify the type of alkalosis, metabolic or respiratory, then to identify its cause, to tailor treatment to chloride responsiveness and electrolyte imbalances, and at last, monitor closely to ensure safe recovery. A structured approach ensures effective management, minimizing complications and improving outcomes. Thank you for your attention.